Dr. Gebremedhin, thank you for joining us and sharing your experience in amending the international guidelines and recommendations for CML therapy to reflect the local needs in Ethiopia. So I'll start by asking you, at which stage of the disease is CML usually diagnosed in Ethiopia?
Okay, thank you. Thank you for inviting me to be involved in this activity. So in our country, in Ethiopia, patients are diagnosed late in the course of the disease because they come to hospital when actually they develop symptoms. As you know, elsewhere, patients are caught when they come for some other medical checkup, and therefore CML is diagnosed early in the course of the disease. The stage of disease may not reflect the actual disease stage in our patients, because the pathologists define the different phases of CML differently. So what we have thought is important is the so-called score, okay, based on the stratification of patients. Therefore, based on that, patients with so-called score low are 21% in our center, compared to around 60% in the Western countries. Intermediate risk group are the most abundant, 62% of our patients, as opposed to about 30% elsewhere. About 17% of our patients actually present with high score disease. So as you can see, our patients come late in the course of their disease. So they are usually in the intermediate and high risk score group.
And which scheme of TKI therapy can you use in Ethiopia? First, second, and eventually third line therapy? And is this available for all of your patients?
Thank you. New patients are given first line TKI therapy, in this case, imatinib. Imatinib is available regularly. We obtain it from Novartis as a donation, okay? And we are grateful for that. So we have never had an interruption in terms of imatinib availability in our center. So when actually a diagnosis of CML is made in our center, we start them on 400 milligrams of imatinib. If the patient has advanced disease, like for example, accelerated phase or blast crisis, we tend to increase the dose of imatinib, usually between 600 milligram and 800 milligram daily. We have also nilotinib, a second generation TKI. For the last 4 years, the hospital actually was willing to procure the drug, buy it from Novartis. And for the last 4 years, we have nilotinib in other. So for patients who fail to respond to imatinib, we actually consider second line treatment, in this case, nilotinib. And the patients respond well. Not all patients, but most of them respond to second line treatment. We obtain other second line, third line treatment modalities for patients who fail to respond to first line, as well as second line treatment, through compassionate use of drugs, including dasatinib, bosutinib, and a third generation ponatinib. We actually can access these drugs through compassionate use, and max access helps us in this regard. So almost all the TKIs may be considered in our patients, but the way we obtain them is different. Imatinib, regular regularly donated by Novartis to our center. Nilotinib, the hospital buys it, and the other TKIs are obtained on compassionate basis for our patients.
How do you make decisions on switching therapy, and what determines your choices?
We decide switching therapy based on response to the first-line TKI, in this case, imatinib, after making sure that the patient is taking the medication. That is the patient adherent to treatment? In the case of non-adherence, then we have to sit with the patient, counsel the patient, and we make sure that the patient continues to take the first-line TKI. But if we really, there are reasons for, change criteria we follow for switching TKI, include in patients who do not tolerate imatinib, the so-called imatinib intolerant patients, patients who do not achieve hematologic response. This could be primary resistant disease, and patients who have, cytogenetic relapse as well as molecular relapse. So in these situations, we consider change of TKI therapy. But unfortunately, we don't have the objective means to assess our patients. For example, we don't do cytogenetic studies in our center, as well as molecular studies are very difficult. Although now we have a gene expert equipment, and therefore we do the BCR-ABL level. So the BCR-ABL level would tell us in which group of patients we can really consider treatment after they have been taking, for example, first generation TKI, second generation TKI for more than 3 months, 6 months. And if the BCR-ABL level is still high, then we consider change of therapy. Unfortunately, we don't do mutation analysis, okay? Except few patients who can send their samples abroad. So the results come in about 2 weeks. We have this kind of patients. They are not more than 30, 40 in our center. So the most important, in our patients who do not respond to treatment, who fail to respond to treatment, mutation analysis would have been a very good guide what TKI to consider in this group of patients.
And how frequently can you monitor the patient's response to TKI therapy?
We monitor hematologic response of tyrosine kinase inhibitor therapy in every 2 to 4 weeks in the first 3 months, when after the diagnosis is made. And after hematologic response is achieved, the frequency of follow-up depends on a very important issue, the distance from the treatment center. Because this is a big country, and therefore, patients come from a very distant areas. More than 76% of our patients have to travel more than 300 kilometers to the center. And therefore, you have to limit, the way you follow the patient, the frequency you do the investigations and so on. So, but the range is, we usually follow our patients from 4 weeks if they are around us, for example, in Addis, to 12 weeks, that is 3 months. We don't give appointments for more than 3 months because this is agreement, the memorandum of understanding we have signed with max access. So the maximum appointment we give to our patients is 3 months. We also plan to do molecular studies every 6 months, okay, since we have the gene expert equipment. And we have reagents now donated by Novartis. So we are planning to do molecular studies, that is a BCR-ABL level every 6 months in our patients, as opposed to elsewhere, they do it every 3 months. But we have to scale down because of availability, non-availability of reagents. Until they achieve measure molecular response. And then subsequently, we are planning to follow to do the molecular studies every 6 to 12 months thereafter. As I said earlier on, this is a scale down from the international recommendations, because they suggest to do the molecular studies every 3 to 6 months. Now, since we don't have, reagents on a regular basis, we are planning to scale down the number of follow-ups investigations we do in our patients.
And are you trying to implement a TKI discontinuation program?
No, we are not, and we will not try to implement TKI discontinuation therapy in our patients, in our center, because our center and most of our patients do not qualify and fulfill the criteria for the discontinuation of TKI therapy. This is because most of our patients, as I said, have intermediate to high risk disease. We don't know the depth and duration of the molecular response in most of our patients, since we don't do regularly the molecular studies, we don't do mutation analysis. There are no reliable facilities to monitor the patients after discontinuation. You have to really closely follow your patients. Like, for example, in the first 1 year or 6 months, you have to do it every month, every 2 months. We cannot do that in our center. So we don't have at least an immediate plan to start TFR, treatment discontinuation in our patients because of the hurdles, the problems I mentioned already.
I understand. What do you feel the biggest challenge is in Ethiopia to fully implementing the international guidelines and recommendations to the full extent?
The biggest challenges in Ethiopia to implement the international guidelines and recommendations may be like the non-availability of reliable facilities, okay? Cytogenetic, molecular for our patients, for the diagnosis and follow-up of our patients. That is for response and also for resistant testing of the patients who do not respond to treatment. So basically, we don't have the facilities on a regular basis. The second problem is related to adherence to treatment of our patients. This has many reasons. It could be economic issues. It could be, as I said, the distance the patient lives from the center. As I said, around 76% of our patients live more than 300, 400 kilometers from the center. So there could be problems of transportation. And therefore, we have, this is really the second most important problem we encounter in our center. The other thing is the availability of second and third line TKIs. In patients who fail to treatment, we have to beg, we have to ask for compassionate use of third line, second line medications, since they are not available in the country, in our center. So we have to communicate with people, and this takes time. The medications may not arrive on time. We have problems clearing them from the customs because these are new drugs. So really, this compounds the problem we have in our center. but we are discussing this issue with the health authorities, and probably sooner or later, we may have a solution for the smooth, use of particularly the second line and third line TKIs in our center.
And so finally, what is the single most important aspect of clinical management of CML patients in Ethiopia that you would like all newly qualified hematologists to know?
Thank you. This is an important question. So I think the most important aspect of clinical management of CML in our country, and newly qualified hematologists should know, is that the early diagnosis and awareness of the population about the disease, treatment and follow-up of our patients in general is suboptimal. So the hematologist should know and actually should act to optimize this drawback. And I would also suggest for the newly qualified hematologists to be CML advocates. They have to advocate, they have to tell people, health authorities about the disease whenever they have the chance. This is very important because actually having treatment alone is not enough. So we have to improve on the awareness of people on CML, early diagnosis, proper follow-up, proper investigation of our patients. I think this is what a newly qualified hematologist should know.
Thank you very much for joining us today. It's been a real pleasure. And on behalf of the ICMLF, can I just share with you how much we appreciate all of the work and efforts that you make. Thank you very much.